If you have any questions, please, as you see the presentation coming to a closure, you can make your way to the microphones. So presenter, Dr. Nicole Branch, is a resident in the Department of Obstetrics and Gynecology in Barbados. Her study, though, was conducted while she was in the Rand Hospital in Grand Bahama in conjunction with the African Caribbean Cancer Consortium. Her presentation today will be entitled Girl Fight: Knowledge and Attitudes Regarding Human Papillomavirus and Human Papillomavirus Vaccine in a Caribbean Population. Let us welcome Dr. Branch.
Moderator said, I am Dr. Nicole Branch, and I am in the Department of Obstetrics and Gynecology. Imagine your daughter, vibrant and full of life. She's all smiles today because it's her wedding day. She's about to marry her one true love. Now fast forward 10, 15 years. Your once vibrant daughter is reduced to a mere shell. She's lying in a hospital bed, and her diagnosis, advanced cervical cancer. And you ask yourself, was there anything I could have done to prevent this from happening? Cervical cancer kills over 200,000 females annually worldwide. It is the second leading cause of cancer-related deaths among women in the Latin America and Caribbean region. In the Bahamas, the incidence was 16.7 per 100,000. And in Grand Bahama, where the study was done, the incidence is 60 per 100,000. The main causative agent is the human papillomavirus. It's a DNA virus with over 100 serotypes. Thankfully, the Food Drug Administration has developed 3 vaccines to prevent us from this deadly virus. There's Cervarix, which is a bivalent vaccine, and there's Gardasil and Gardasil 9, which protects us against the oncogenic serotypes. In a study done in Nassau by Halliday et al., it was found that there needed to be more education in regards to human papillomavirus. And furthermore, in a study done by Perkins et al., with the increase of this education would lead to increase in the vaccine acceptance. Therefore, this led us to our study entitled Knowledge and Attitudes Regarding Human Papillomavirus and Human Papillomavirus Vaccine as they relate to cervical cancer among female patients in Grand Bahama. Having given my background, I will now proceed with my aims, followed by my methods, results, discussion, give my conclusion, and also some recommendations. Aim: to determine the knowledge and attitudes towards HPV and the HPV vaccine among females in Grand Bahama in order to inform educational strategies. So how did we do this? So it was a cross-sectional study in which the calculated sample size was 382. However, we had 403 participants. We saw ethical approval, and it was a validated questionnaire containing 51 questions that we distributed around Grand Bahama, all the clinics in Grand Bahama. Data analysis. We carried out descriptive statistics and measures of knowledge and methods of association using t-test and ANOVA. And all data was analyzed on Stata version 13. Results. As you can see from this graph, most of our population was between the ages of 18 to 35, as demonstrated in blue. In terms of marital status, most of our participants were never married, again demonstrated in blue. And in terms of education, most of our participants had secondary level education, which was 53.3%. Most of our participants earned less than $25,000 annually. And in terms of sexual habits, most of our participants were sexually active. The mean age of sexual debut was 17.5 years, and the maximum number of sexual partners for a participant was 461. In terms of cervical screening behaviors, 85% of participants actually had pap smear done, and 7.9 had them done 3 yearly. The majority, however, had them done every year. In terms of general knowledge of HPV, almost half of the population had a score of 0, and about 20% had a score of 4 and above out of a possible 8. So I wanted to highlight the questions that we asked to ascertain the knowledge of HPV, and mainly 23.8% knew that HPV was sexually transmitted, 20% knew that HPV caused most cancers, and 36.7% knew that most cancers could be prevented. In terms of knowledge of the HPV, it was found that knowledge was lower in the lesser educated and in those who had a lesser income. Moving on to knowledge of the vaccine, 24% heard about the vaccine, and of those who heard about them, 19% actually heard about them from healthcare professionals, as demonstrated in the red. Out of a maximum score of 5, the mean score was 1.7. Less than 1% heard about 2 or 3 HPV vaccines. 25% knew that there were FDA-approved vaccines that protect against genital warts and cervical cancer. And the majority of participants knew that although you were vaccinated, you still needed to have your pap smears. Moving on to the attitudes, this slide just shows what we use in the questionnaire to ascertain about the attitudes, and to bring your attention to 3 points. That if you did know about the vaccine, you would recommend it to your friends and relatives. However, they state that there needed to be more reassurance in terms of the safety and efficacy of the vaccine. Discussion. So there were knowledge deficits regarding HPV and HPV-related issues as compared with the Latin America and Caribbean and the Nassau study. And the knowledge was lowest in the less educated and in the lower income. And among those with knowledge of the vaccine, there was acceptance, but they said that reassurance was needed. And with increased knowledge may lead to increase in vaccine uptake. So limitations. It was a non-random sampling. However, given the literature review, our results were comparable. And it was done at multiple sites in Grand Bahama. However, Grand Bahama only makes up one of the many islands of Bahamas. Conclusion. Cancer screening practices were acceptable, and there were numerous knowledge deficits. Attitudes towards the vaccine were acceptable towards those who knew about the vaccine. So recommendations. We recommend that there need to be more educational programs. We can first target the primary schools, and we can also do community-based seminars in which we do sexual health guidance, and also to increase the awareness of the HPV vaccine. We can also use social media. My age group is always on social media. Facebook, Twitter, we can use this to aid awareness. And after we do these things, we need to monitor and evaluate the response after these implementations. So, having given my presentation, I still wanted to give you a sense of what a patient feels after they get the diagnosis of cervical cancer. And I interviewed 2 patients who would now share their experience.
So it was difficult for him
says finish, actually. Together, we can prevent the spread of HPV and cervical cancer. Get vaccinated. These are my references, my acknowledgements, which includes the rest of my research team. Thank you.
Do we have any questions for Dr. Branch? Okay, thank you. Okay. Our second presenter, Dr. Judith Green McKenzie, is an associate professor, division chief, and residency director in occupational and environmental medicine at the University of Pennsylvania Medical School. She is a diplomat of the American Board of Preventive Medicine, Occupational Medicine, active in clinical practice, research, education, and administration, and is a senior fellow of the Leonard Davis Institute for Health Economics, the graduate program in Public Health and Prevention Research Center. Dr. McKenzie graduated from Princeton University, receiving an award for leadership and scholarship. She studied medicine at Yale Medical School and was selected as a Commonwealth Fellow. She also has completed her Occupational and Environmental Medicine Fellowship, Masters of Public Health and Epidemiology Research track at Johns Hopkins, again receiving research awards, and also was recognized by the American College of Occupational and Environmental Medicine, honored for her lifetime achievement and excellence in education and research. She has been involved in numerous scientific publications and has produced many publications related to outcomes in occupational and environmental medicine and in worker health. Dr. McKenzie today will be speaking to us. Oh, I'm sorry. I have to remember this. Sorry? Yes, we'll be speaking to us on healthcare provider burnout. So let us welcome Dr. McKenzie.
During my talk, I'm going to talk about the definition of burnout, how it's measured, the prevalence, causes and consequences, and successful prevention strategies, and then the way forward. So how many of you would say, someone close to you would say that you have a healthy work-life balance? Not that you think you do, but your kids, your parents, your sister, that you have achieved a healthy work-life balance, if you raise your hand. It's about 4 people, okay? So maybe we do need this talk after all. So what is burnout? It was identified about 30 years ago and started being explored in healthcare providers about in the 1970s. It's actually the end-stage consequence after exposure to relentless stress in the work environment. It's defined as exhaustion, physical, emotional, because of prolonged stress. It's actually a pathological condition. It's not just okay to have burnout. And it's a state of fatigue and frustration because of too many demands on your resources, too much out and not enough in. And it doesn't just affect healthcare workers and service providers, although that's what the early literature said. It can really affect many worker populations. And in terms of the definition, there are 3 central constructs. One is emotional exhaustion, where you're emotionally drained and exhausted by your work. 2 is depersonalization cynicism, where you feel negative towards your patients or to your clients, you're detached. And the 3rd is reduced personal accomplishment. You may come up here and give a fantastic speech and you think, oh, it was okay. And everyone's saying you did really well and you just can't accept it. You're not happy with your positive job performance. You think you're just not doing as well as you should be doing. And it's not stress. You may say, oh, this person is stressed and so on and so forth. It's not really stress, and it's not depression, it's not fatigue, it's not anxiety, it's not that you're lazy, it's burnout. How is it measured? Maslach et al. Developed this scale. It's called the Burnout Inventory Scale, or MBI. It's often used as the tool to measure burnout in healthcare professionals. The scale has also been adjusted for other professionals, such as professors or other types of workers, students. And it incorporates the 3 constructs, which I talked about before: the emotional exhaustion scale, feeling just totally wiped out; the depersonalization scale, where you just don't have feeling for your patients. I heard a story of a resident who would see her patient lying in bed and wished she were the one in bed because she was just so tired. And the personal accomplishment scale we talked about before. The long scale is about 22 questions per section or so, and there's an abbreviated scale which is about 9 questions, which we actually handed out to you when you first came in. So if you fill that in, we can feed back to you through Dr. Chin as to how this group is in terms of burnout. It affects healthcare workers at every level: nurses, medical students, residents, physicians, and some specialties more than others. In terms of nurses, a very fast-growing profession and very high burnout. 49% of nurses under 30, and as you get older, 40%. I guess maybe the attrition, the ones who burn out kind of quit, and then the ones who sort of are able to manage their stress stay longer. That's just my assumption. Nurses with burnout syndrome, they're very negative about their responsibilities, they're less innovative, and they have less overall performance on a day-to-day basis. I was inquiring about the length of shifts here in the Bahamas. Apparently the nurses do 8-hour shifts mostly, is that correct? In the US, nurses mostly do 12-hour shifts, and the hospital likes that, and the nurses like that because it gives them more time for their, they get days off and they can do their personal things with their kids or go shopping and so on during business hours. But research shows that first, for every extra patient added to the nurse's load, it increases their burnout by 23%. And with extended shifts, that also increases their burnout. And a lot of times nurses are asked to work overtime voluntary, but sometimes it's not so voluntary. They say, we really need you badly, so they do it, so it's not really voluntary. And nurses who work 10+ hour shifts are found to be up to 2.5 times more likely to experience burnout and actually leave their job than those who work shorter shifts. So stick with 8 hours. In terms of physician burnout, 1 in 2 physicians suffer burnout symptoms. The research over the years has shown that percent has been creeping up. And 45% of primary care physicians said they would leave medicine if they could afford it. And in terms of internal medicine residents, you can see like 2/3 of them, more than 2/3, said that they've had burnout at least once during their residency training. Medical students, when they graduate college, they actually are better off than their peers graduating college. But by the time they get into medical school, this starts with them. Poor well-being, and it just seems to get worse through residency and can also persist into being an attending. The largest study on burnout in physicians was done in 2012 by Shanafelt et al. And the response rate was only 26%. So, you may say, well, did people who are more burned out respond or people who are less burned out respond? We don't really know. However, it was a huge sample. It was over 7,000 doctors, and it was a comparison of the general population, over 3,000 of the general population. And they use the MBI, which I talked to you about, the long scale, which is over 60 questions. They found that burnout was higher in physicians than in their control peers, and satisfaction with work-life balance was also lower. The question is that it does not leave enough time, a negative question, and it was higher in physicians not having enough time. And by specialty, emergency medicine was the highest. I apologize for all the emergency medicine physicians. It's actually the frontline specialties, so like emergency internal medicine and neurology is up there, family medicine is up there, and the lowest burnout would be preventive and occupational medicine, which is what I do. But that doesn't mean I'm not susceptible, because as you can see in a future slide, even though preventive medicine is the lowest, it's still 30% of preventive medicine doctors who not just say I feel burned out, but actually are found to be burned out from the scale. So that's still pretty high. That's 1 in 3. In terms of are you satisfied with your work-life balance, again, preventive medicine is the most satisfied. Dermatology, which I can believe, my neighbor's a dermatologist, and every Wednesday is her bonsai day, and she really takes time for herself. I'm a little jealous. And again, surgery is the least satisfied, and surgical subspecialties and obstetrics. Again, I just talked about the burnout, 30% with the lowest specialty. And I just want to bring in a general population besides healthcare professionals. There was a study in Taiwan that looked at workers who presented in a medical clinic, and they found that those working more than 40 hours had a higher rate of burnout, and those over 60 even higher, and there seemed to be a dose-response relationship. So certainly spending more hours in work gives you less time for leisure and self-care. And self-care is important. I found that in the medical profession, we sort of think the patient comes first, but the fact of the matter is if you don't take care of yourself, you really don't have much to give to the patient. I was sort of looking through the, the web, and I found that the Tribune, which is your paper here, talked about guarding against personal burnout. This was in 2013, so it's come up here, obviously. And they talk about karoshi, which is the Japanese term for working yourself to death, where some of the stories were with Japanese young men not taking days off for years, and at age 32 or up to 40, they would just die from a heart attack. And that's where this term comes from. And again, another article I found was that concern over 12-hour shifts for police, and from the data that I've reviewed, 8-hour shifts seem to be the sweet spot. So why do people get burned out? Administrative burdens, especially for nurses and physicians, all the charting that you have to do, which just keeps increasing. An inefficient work environment, you're supposed to use gloves, you can't find the gloves, you're supposed to use a safety needle, you can't find the safety needle, you're supposed to wear a nurse respirator mask, you can't find it. Loss of autonomy, unless you're in private practice, if you work for an institution, a hospital, loss of autonomy. Loss of flexibility. If you have kids, you can't get home in time. You may say you want to meet someone for dinner at 7 o'clock, then a patient crashes, and there it is, it's over. You get a call at 2 a.m. that your patient is coding. You have to wake up and go see them, which happened to one of you guys apparently last night. So there's the resources, expectations, and job realities. There's a discrepancy. Too much is expected with too little. Again, long hours and sacrifice, high demand, low control. You're supposed to do research, but where's the research time? And this is US data, but I think it's transferable after talking to people in the audience. And also, you're caring for people who are sick or they may die. And do you have the resources, or do you have a place to go to talk about someone who died? Even if it's not your fault, you're still mourning in a sense, and being sleep deprived. So there's less personal meaning with your colleagues, less meaning in your work. It's very difficult to integrate your personal and professional life. If you're not married to a healthcare professional, then you may not be able to really talk about what you're going through, and then you don't have enough time for work-life balance. Unrealistic expectations, you're afraid to make errors because the litigation threat, which is less so here in the Bahamas, but it's certainly very huge in the States, and there's a lot of defensive medicine. In terms of residents, yeah, I'm sure the residents here can probably relate to this. It's long training, and we're taught delayed gratification. One day you'll get to the end, and you'll be this great doctor and do all these great things. But why is it okay to have delayed gratification for so long? I mean, maybe we need to have a paradigm shift on that. It's long working hours, a lot of workload, being on call, feeling overwhelmed, time pressure, social demands. You can't go hang out with your wife, your friends, whoever it is. And also, maybe residents, depending on the level of training, they may not have the skills to do what their attending wants. So they may be grilled at morning rounds and they feel terrible. They don't know the answer, but they're not quite there yet. And that's certainly a stressor. And again, they're exposed to suffering, illness, death, and dying. Adverse patient outcomes, maybe because of them, and they feel terrible. Who do they talk to? How can you say, oh, I made an error? You know, the speaker earlier this morning said, oh, I made a mistake. Are we allowed to say that? But there should be a forum for us to say that without feeling bad about it. And also, it's a lot of technical training and not so much how do you handle these issues. Residents, again, have limited control over what they do. They're told to do this, that, or the other. The work environment might be a little hostile, where they're under pressure to produce when they can't really do it. They may be worrying about how much money they have, and they may have a family, and what am I going to be when I grow up? Maybe an occupation as a physician. I don't know. Not enough self-care, or bit sleep, diet, exercise. You see the stiff upper lip, be strong, and do what you need to do, and forget about sleep. Well, sleep is important, as the research is showing us more and more and more today. Social isolation, because you don't have the time to hang out with your friends, and imbalance between career and family. You can't go to church, you don't have the time, you have to see patients, or you have to catch up on your sleep. So the culture of medicine does exacerbate burnout. The strong and silent type is revered. You should never show weakness. Just work your long hours. And if it's very high stress, just be gracious. Don't get angry. You know, the people who are just always gracious, they're the ones that we really respect. You're supposed to sacrifice your life and meet the high demand, never get tired, and stay late and work day or night. So what are the consequences of burnout? You know, it's great to do all these great things and be this great doctor and always be there for your patients and for your residents and do all this research, but what are the consequences? So professional consequences, remember we talked about the 3 different constructs, the emotional and the depersonalization. Well, in terms of depersonalization, the consequences are that you're less altruistic, you're not able to express empathy, rather. You may be hostile to your patient. You know, you're tired and you have to take care of this patient who's sick, except for this present company excluded, of course, and disengagement from your work. And you may have poor judgment in making decisions, less patient safety, less dedication, less quality of care, and increase in adverse patient events. And this has actually been documented. So, you know, we may think individually, it's certainly not me, but, you know, that it's somebody else, but it is there, and increased lawsuits. And also turnover, nurses leave and doctors leave. If the doctors can afford it, they're leaving. So then the institutions that with staffing shortages, it's very expensive to actually hire new staff or to do without staff, and then you have more burnout for the people who actually stay. The hospital morale is reduced and the institution loses financially. The patients actually do perceive this reduced quality of care, and you get lower patient satisfaction if you do satisfaction surveys, may end up with lower scores. Even in surgery, there's a longer time to discharge. So the outcome is negative for the patient and for the healthcare provider. In terms of personal consequences, you're there, but you're actually not there because you're just so tired or burned out, so to speak. You call out sick, or you take sick leave for an extended period of time. You utilize the healthcare system more. Physical health needs, risk of needle stick injury, and report feeling stressed. You may have trouble dealing with your coworkers, and you're just not happy overall. And it's related to mental health impairment. Physicians actually now at this point have been shown to have the highest suicide rate, more than used to be dentists, I think, but we surpassed them. In general, male physicians have a longer life compared to the general population, but suicide is overrepresented as a cause of death. In fact, one statistic that kind of shocked me is that for each year, 3.5% of a graduating class of medical school will die from suicide in terms of physicians, which is really scary. Before internship, the surveys show that 3.9% of interns may be burned out, and then depressed rather, and by the end of the year, it's up to 26%. So how can we help our trainees not go through this? So in mental health, there's increase in all these things: depression, anxiety, scoring on your exam, that you have to take, substance abuse, accidents, marital discord, and so on and so forth. And another study show that loneliness does contribute to burnout, so those with greater burnout scores also had greater loneliness scores, which sort of makes sense. If you don't have social support, you have no one to really talk to, that might increase. So how do we prevent burnout? Coping mechanisms have been shown to reduce this in healthcare workers. One study had a wellness curricula for their workers, where they taught healthcare professionals how to improve self-care. Some conduct formal wellness programs with yoga, healthy eating, counseling that's easy accessible, stress management workshop, and mindfulness. So what is mindfulness? Has anyone here practiced mindfulness? Couple, 3, 4. Yeah, so yeah, mindfulness actually does work, and studies do show that. Mindfulness means paying attention in a particular way, on purpose, in the present, and non-judgmentally. So if you sit for a minute, you can even time yourself and sit for a minute and count how many thoughts run through your head. I'm sure even as you're listening to me, you're having thoughts about what's for dinner and so on and so forth. A lot of thoughts run through your head. What mindfulness does, it quiets those thoughts, because you're supposed to focus on your breathing, and whenever a thought, you just non-judgmentally push it away and just focus on your breathing. You can do it for a minute, you can do it for half an hour, and it really does work. There are also apps on your phone for that. So mindfulness-based interventions will help with self-reflection, self-awareness, and actually lead to increased personal well-being and increased empathy. How can organizations help? Well, they can educate healthcare workers on stress and educate them how to identify that in themselves and in their coworkers. They can actually have places for people to go and talk about these things. If a healthcare worker is seen to be approaching burnout or to be burned out, maybe follow up with them and have easy access to confidential counseling. We need to have a culture where we can actually feel comfortable saying, I need help. And also teach resilience. So what's resilience? It's how you bounce back or withstand hardship, prepare yourself in the face of stress or a disruptive change. It's based on internal attributes. It could be genetics or just having an optimistic attitude. It could be modeling. You may see an attending here who seems resilient. You may want to be like that person. And it's also problem solving and finding purpose and meaning. So how do you build resilience? Exercise, sleep, eating well, supportive professional relationships, taking time out, and think back to when you were a kid. What did you enjoy doing? What's your hobby? We see Dr. Chin here, she likes fishing. So she's doing that, that's a good thing. And also have boundaries. I was talking to a colleague of mine, and they were piling on more and more work, and they said, I still need to brush my teeth. And he said, oh, you mean you need to do your ADLs? Yeah, I need to do my ADLs. You still need time to do your ADLs, so say no. If you can't do it, just say no. You're really not helping anyone by overextending yourself in the long run. Take time away from work, and you'll have more of a passion for your work. You can think of your body as a tank where you have all the positive things. You have all this psychosocial support and all this nice mentors and people you look up to, like our professor here. And then you have all these other things happening: stress, internal conflict, time demands, energy demands. If it's more negative than positive, then it's not going to work. So you have to look at yourself, assess yourself, and see what you can do. I like this picture because it sort of has all the different things, burnout busters, this word diagram, meditation, health, exercise, spirituality. I just thought I'd show that to you. And so obstacles to resilience is not taking time for your work and personal life. And I'm giving you permission to do that, because I think sometimes it's difficult because you think you have to be on call, you have to take care of you have to do all that. Well, yeah, but you also have to take care of yourself. You need to spend time for rest, relaxation. You can play a little bit. You need to recharge your batteries, right? I remember I was talking to my brother and I said, I have all this. He said, yeah, but you need to take the day off, recharge your battery. I said, thank you. Thank you for telling me I can do that. Get sleep, okay? And also social isolation is a big one. There's this model called the Karasek model, the job demand control model, and they found that people who work high demand and have high control, they do well. If they have high demand and low control, they do not do well. If they have low demand but low control, they also don't do well. So control is an issue. But the thing that was able to moderate or modify all of this was social support. So regardless of where you fell in the box, if you had good social support, you did better than if you didn't. So social support is so important. So going to a new town not knowing anyone is not necessarily a good thing unless you have some social support. So plan ahead. Also overexposure to stressful events, emotional overload, not enough time to process your feelings. Things happen, you need time to process what happened. And also being a perfectionist, which I think affects a lot of healthcare professionals. We want to make it perfect, but it's okay not to not be perfect, be proficient. And also, if you don't tolerate mistakes in yourself, how will you tolerate mistakes in others? Then you become sort of, is that my time? I'm also cognitive dissonance between the ideal and reality. Unaddressed mental health issues, we may have residents who come in, they may have ADD and they may not have recognized it when they were younger, and now they have all these things to do. It doesn't mean they're a bad person, they may just need a little help. And also there's a culture of shaming in medicine that we need to remove. Top management needs to be involved. It's not just a healthcare worker, hey, do all these things for yourself, do some yoga. There has to be help from the institution. It has to be a culture. And one of the programs showed that for every new hire, they had to talk to a psychologist, and it was an open door for them. Nothing was wrong with them necessarily, but they had that open door. Again, these are the things that you can do, exercise. So make self-care, wellness, connectivity, and resiliency the norm of your institution, and that will help everybody, as well as the bottom line. So changing the culture, fear of privacy because of your personal health information may be out, prohibitive costs of actually getting help, time pressure, social acceptability, all these things to change the culture so healthcare workers are more likely to ask for help. remove barriers to accessing care, paid time off to do these sessions. One study gave people actually an hour off to actually do the sessions that were provided, and it really worked, made a difference. So the way forward is make it integral to your environment. There is a burden of suicide. There are untreated mood disorders. Doctors are humans, so we are in the continuum of the human race, and we do have our issues, so those need to be addressed systematically. Destigmatize calling for help, no culture of shame, and also no humiliation of residents and physicians if they don't know the answer. So the way forward, reducing burnout through system-wide interventions will see benefits in patient satisfaction, healthcare provider satisfaction, and institutions' bottom line. I just have this picture here I'll show you briefly. We can see these hazards. There's this one young man who's diving for conch. He might have the bends, right? There's another person blasting concrete, silicosis. Another picture with a wrist drop and basophilic stippling, lead poisoning, and a healthcare worker preparing to deal with an Ebola patient was really just a drill. But how do we see burnout? Do you have a rash? Do you have to wear a mask? Like, you know, how do we know? So it's an invisible workplace hazard. Is it inevitable? Is it, well, you're a doctor, so you need to deal with burnout. So what is work? It's been around forever. By the sweat of your brow you shall eat bread. Without work, all life goes rotten. But it can be hazardous to your health. Camus says that when work is soulless, life stifles and dies, and that's what's literally happening when people commit suicide. Ideal work where the talents and needs where your talent and the needs of work cross, that's really nice. That's Aristotle. Steve Jobs says, do what you love. We don't all have that opportunity. And the OSHA General Duty Clause says a place of employment free from recognized hazards. And burnout is a hazard, I think, at this point for healthcare workers. So wouldn't it be great if we have an ideal environment for a healthcare professional with work-life balance and safe from the occupational hazard of burnout? Thank you. Any questions? References?
Do we have any questions for Dr. McKenzie?
Which professions burn out?
I'm sorry?
Which profession have the highest prevalence of burnout?
I think, yeah, from what I've read, the medical profession does, yes.
Which one? Which specialty?
Oh, surgeons, internists, family medicine, neurology, yeah. It says a frontline, I don't know how to close this. Do you know how to? The frontline professions, that's what they say, yeah. And surgeons have the lowest work-life satisfaction.
Dr. Shrikant?
Even though you did say that the burnout process is probably time immemorial, is there any kind of studies over the decades that suggest that maybe the incidence is higher, or is it just the fact that we are trying to recognize it more now? Or I'm just trying to across generations.
Yeah, from
Generations of, because when you look at the literature that says that the post-World War II generation that didn't have a lot of facilities and other things, hard work was the norm for them. And as times progressed and as the living standards improved, the symptom of burnout or complaint of lack of satisfaction with the job seems to have increased.
From the studies that I reviewed, and I reviewed quite a few of them, most of them are actually, post 1960, but in general, the incidence of burnout is increasing, and the incidence of burnout in physicians is increasing. So I think it's something from our society as a whole, where we just expect so much. It's not just take care of the patient, which I think people get a lot of satisfaction from, it's also do the paperwork. It's also, you only have 20 minutes with the patient, or maybe 15, then you have to see the next patient. Well, what's 15 minutes going to do? So the patient's upset, you're upset. And then also because it's such a work, there's so much to be done with all the added bureaucracy that, well, when do you really have time to go out and do anything, for yourself? You really have to make that time. And from the research that I've seen, the best way to do that is through the institution. It's not okay to say, okay, Dr. Chin, why don't you go and do some yoga after work? Well, maybe after work you have 10 kids to take care of. I know you don't, but if the institution actually is involved, it makes the studies show that it makes a big difference. Sorry?
The medical chief of staff.
Oh, hi, sorry. Do you have time for one more
I think
question?
there was one more question.
She had one.
You're going to have to project your voice.
Good afternoon. Thank you for your talk. Very interesting talk. It's a very timely topic. It's something that has been coming up quite frequently now in the U.S. But I wanted to point out that we have also began to consider this in our Bahamian population. Back in 2014, the first year family medicine residents actually conducted a study on burnout here. And what our results showed was very interesting. We had over 55% prevalence of burnout among our physicians working in PMH as well as the family medicine Agape clinic. And what we found was that our highest prevalence of burnout was across internal medicine, as you've shown previously in your slides, as well as pediatrics, and of course, emergency medicine. Now, family medicine was also, I think family medicine was about fourth for us. What we found was that the cause of burnout in our population was number of years post-internship, meaning that individuals who recently completed their internship were at the highest risk for burnout versus those who were at the consultant level. And also lack of appreciation is what we found to be one of the
That's
main-
social support.
Right. And we repeated the study in 2015 to incorporate the physicians who are on the family islands and to cover the other physicians who work inside the community clinics. And there we found that in Grand Bahama, the prevalence of burnout was 61% in Grand Bahama, yes. We
Did
have a
you-
serious problem.
Did you use the
We
MBI?
we used the Maslach burnout
The
inventory.
long scale or the short scale?
The 21 question, the 21 question survey is what we use.
Have you published?
We are in the process of publishing.
Because I
both
searched the
programs.
web.
Yeah, we're in the
Well,
process.
I'm looking forward.
We're in the process of publishing.
Looking
But the last
forward.
thing I wanted to say is that in both studies, it was found that lack of appreciation was the main cause of burnout in both studies. So point for consideration.
I can't find it. Okay.
Not at the expense, not at your expense. I think what we should be aiming for is quality patient care and quality in terms of their treatment and management, but quality of life for the physician and the health professionals as well. And I find that there is never a question asked in our community, and we might as well face it. Nobody ever cares what's going on with the doctor. It's how can you help me? And there's no consideration given for, your workload, how tired you are, or whatever, your life issues that are going on. And I think we need to be more proactive in that sense in terms of offering that ability to express that for our physicians to be able to express that without feeling
Without judgment.
Judgment, exactly. And I think that's a cultural thing as well.
Yep. Thank you, Dr. McKenzie. And thank you for those very thoughtful questions and contributions. So I'll remind the attendees, the code for this session is HPV 1618. And I would like to ask those of you with mobile phones in the audience, please either put your phone on vibrate or on silent. Thank you. Our next presenter, Dr. Glenn Jones, is a clinical epidemiologist and radiation oncologist practicing in the Bahamas and in the Eastern Caribbean. He is an associate lecturer with our local UE School of Clinical Medicine and Research, and also is affiliated with the University of Toronto. His primary research theme is to improve, to prove, and transform the value of healthcare through studies and analytics that focus on optimizing causal relations through bigger clinical data sets. His passions include teaching research methods, data management and biostatistics, and expanding psychosocial and supportive care to address patient distress. As a teacher, he has had a mentoring role in numerous research projects. Today, Dr. Jones, the subject of his presentation will be clinical outcomes in non-metastatic prostate cancer treated with radiotherapy and hormones. Let us welcome Dr. Jones.
All right, I'm very pleased to be here. This is a talk around the oncology in terms of prostate cancer, and I'm doing it on behalf of a team which I'll show in a second. It's the Cancer Center Bahamas data, although currently most of my practice is Antigua for the OECS. So if you want to look me up on the internet, the best place to go is researchgate.net, and just search for my full name, which is shown there. Okay, so the team is shared management with Dr. Roberts in urology, Dr. Monroe, and then several other doctors who are here locally. Chelsea Brown helped with the student component of this to identify many of the charts from a larger set. The research partnership at the Cancer Center has Dr. Smith and Carla Adderley was working there and helped extract the data on PSA. The Cancer Clinic at the Bahamas has the first two of the physicians presently there, and I do coverage occasionally, and then medical physicist and a radiotherapist. And at the medical pavilion, the two Drs. Browns helping out in terms of assembling the charts and so on. So the outline for this is to do what is the rationale for cohort analytics. You know, nowadays, because randomized trials are usually considered to be the level 1, initially clinical reviews evolved into academic reviews, and academic reviews got replaced with scientific studies like randomized trials, and they got replaced with meta-analyses. So now it's all derivative work, and you see a lot of publications of guidelines, meta-analyses. It's easy to do. It's off your laptop, desktop, do on the weekend, whatever. And you're actually far away from the actual frontline data. But there's a lot to learn from the actual data that is coming through. Terabytes of data are probably collected at the hospital here on a daily basis, and yet probably very little of it's analyzed. So the question is, can you use that? So I have a main research idea and question in terms of the talk as a sample or an example of that. I'll give the design sample and so on, and then refer the results to the literature in terms of benchmarking, which is the primary focus of this. But I'll talk about other reasons why one would do this kind of study. In terms of limitations, there's one main one, and I'll cover that, and then we'll talk about further development or what this might mean. So the Cancer Center in the Bahamas has been active since January 2004, and chemotherapy from about 2009, but radiation from the beginning. So there's about 2,500 patients that have been managed. 1,800 have been managed by radiation oncology, of which about 350 are prostate, which includes about 50 palliative cases, 50 who decided not to have radical treatment, and so on. 650 breast cases, 450 cervix and endometrium. The question is, could one learn anything from actually looking at the data from those patients that's been assembled? Now, to date, no presentation or outcome reports have actually been compiled and presented. So why summarize this experience? Well, all of the above actually applies. It's like if you want energy independence, you should do all of the above, right? So drill, develop nuclear power plants, et cetera, right? So all of the above reasons to look back. So you want to assess how the patient's presented and see if that's been changing over time, and also waiting times from the diagnosis to the treatment. These are important quality indicators in oncology. This motivates screening and greater clinical pace to meet the challenge of a new diagnosis. Then you want to compare your outcomes with the literature and practice guideline benchmarks. In fact, if you just look at your survival plot or your time to an event or the proportion of events in any diagnosis, you can actually, or recovery, it's really an end-to-end quality assurance check on what's actually happening. You can do quality assurance in each step along the process, but until you've actually looked at the whole process, you're not really sure how each one is contributing or even potentially counteracting each other to actually diminish quality. So you want this data. Local data is useful for informed consent, because then you can tell patients exactly what happens to your patients, not what happens to those that go to Stanford University. But you can also do advocacy. Now, it will also stimulate the clinical and the research team to evolve clinical management, because once you do a clinical audit, as you know, the classical clinical audit is you find the way patients are managed, figure out that some weren't managed exactly like they're supposed to, and so you actually then share management plans going forward on the patients. So it develops multidisciplinary thinking, which is a significant improvement in quality in oncology. Now, if you get a lot of big local data analytics, you can generate pathways for optimization, because regression analyses across the large data will actually show you trends in certain directions. And if they in fact make sense, many of those should be implemented without moving to randomized trials. So you may in fact be able to show systematically over time optimization of your outcomes from your own data as your policies are changing. And it's also a ground to identify and do local prospective studies. So if you've got some data, then it actually stimulates a lot of questions. If you have no data, then you really are basically without any questions. So data quality and cohort size can also satisfy end of probation criteria for joining clinical trials. So if you want to be clinical trials ready, then you need to be able to demonstrate that you can collect data, that you can actually, and that it looks valid when you actually run an analysis, out pop pretty reasonable numbers. It's not all over the map, and you don't have a lot of missing data. So in this case, for prostate, the specific research idea that I had was that guidelines summarize best evidence to support a course of action. And for a guideline to be locally valid, there should in fact be in-context studies. So this is really a check on the external validity of a study or a guideline. It's also called effectiveness research in some areas, but it's not exactly that I'm getting at. And it's also assessing the applicability of the guideline. Now, there's limited research in the Caribbean population in men with prostate cancer, so it's unclear whether North American guidelines, like the National Comprehensive Cancer Network, would actually apply. And correspondingly, what randomized trials would we actually want to do if we wanted to design one? So without any data, we can't really say. So you can just assume that the average male with prostate cancer in the Caribbean has the same disease as in North America. It will behave the same way from treatment, and all the outcomes will be the same. Actually, most people don't believe that. They actually claim that the male prostate cancer in the Caribbean is actually worse. So this is why I was interested in this question. So the null hypothesis would be that prostate disease here is actually not significantly worse in outcomes when treatment is given appropriate to risk groups. And there's some corollaries of that. Disease remains equally responsive. It's not intrinsically more aggressive, and or less responsive to treatments. The second corollary would be that if that's true, then screening measures such as PSA screening, which is not generally being done, would actually significantly improve outcomes through earlier detection. And in fact, in many cases in cancer, early screening detection actually produces 10, 20, 30% improvements in survival. And it's very hard to show for modern treatment advances those kinds of increases. So in an unscreened population, if it's really true that early detection leads to better outcomes, this is in fact a much more significant step than trying to manipulate treatments, at least at the beginning. So the methods are, it's a retrospective cohort study, which is of course a significant weakness because it's not a randomized trial. Sample are all men treated with, at the cancer center with radiation for those years, and grouped according to PSA, pathology Gleason score, and the digital rectal exam T-stage for the prostate in terms of the extent or anatomic extent of the disease. The time to radiation from diagnosis was a median of 203 days. days, 137 for those that did not get hormone treatments, and for those that started hormone treatments first, it was 219 days. Now, right off the bat, I can tell you that the Canadian numbers in Mississauga, where I worked last year, for 500 men, the median time was approximately 180 days, and it was 93 days for no hormones, and about half a year for those with hormones. So actually, we don't seem to have a significant waiting time. And studies show that a wait of a month in prostate cancer makes no difference to survival, but a wait of a month in breast cancer to radiation or to head and neck actually has an odds ratio about 1.14 to 1.2, which indicates several absolute % reduction in local control if you wait an excessive month. So just a 1 month makes a big difference, and some of that translates into distant metastases and a reduction in overall survival. But in prostate cancer, that's not really the case. Here, the waiting times are quite reasonable. Treatment in this case was 70.2 gray to the prostate. Now, current prostate treatments are about 78. So this is a little bit of a lower dose. So the comparator groups for benchmarking would obviously be those that have lower doses. If the pelvic lymph nodes are treated, they're treated to 45 gray, largely because of bowel toxicity, and there's no reason to escalate the dose. And also, those patients generally are getting hormones, which also concurrently treat any lymph node involvement, so you don't need to overdose the lymph nodes. But the prostate disease tends to be fairly resistant to radiation, so you actually have to take it to a higher level. So put this in perspective, breast cancer is treated by 50 to 70, lymphomas are 36, some palliative treatments are 20 or 8. So just to put it in perspective, this is a relatively high dose. Outcomes of interest are survival, disease-free experience, and PSA profiles. And statistics are Kaplan-Meier, log rank in this case, and using Stata 14.1. So these are the subjects. So we were actually able to assemble 207 cases, and there were 19 low risk, 74 middle risk, and 114 high risk. The predominant, compared with North American series, where this would be flipped around, the number of Caucasians in this series, although they live in the Caribbean, but the number of Caucasians only 14 out of the total, as opposed to seeing something like a 75%, 25%, or something like that. In terms of family history, I did have charts at this point which did not actually contain the family history, so those are question marks, and a negative, like no family history, but declared that nobody in the family has breast or prostate cancer, and related to the index patient is given here. And then this is the number 3 males here with low risk disease had at least one male relative who had prostate cancer, but in this case, and/or breast cancer in the women, but that's not shown here. And then there's 3 where there was just the women had breast cancer, and I think one had one male breast cancer. So if you actually look at this, then you get about 40 or so individuals to 50 out of the 200 actually are already declaring positive family histories, which is interesting. And it's not significantly different across the 3 groups there, whereas the ethnicity actually was. Now, in terms of the age, the mean diagnosis is a little bit younger maybe than in Canada. It would be about 65, 66 in Canada. So this is a little bit lower, even though ours are screened. Ours have PSA screening, mostly. So these are slightly younger. Disease could be a little more aggressive. There's no difference across the 3 risk groups. Now, the low risk group are those that have a PSA less than 10. The middle risk would be 10 to 20, and high risk is 20 or over. And then you substratify. If you haven't met that criteria, you go to Gleason score. This would be, you have to be Gleason 6 or less here. This is it could be Gleason of 6 or 7, and then this would be 8 to 10, and then the T stage, this has to be T1 or early T2. The middle risk similar, but high risk would be T3, which means the disease is extending outside of the prostate into seminal vesicle or adjacent tissue. So those 3 criteria are grouped, and so in the next slide, what I do is show you the main factors. So same number of patients, PSA, the mean PSA, these all have to be less than 10, so the mean PSA is 6.5, 11.8 because this is 10 to 20, and it's on the part of the downside of the curve, so the mean is actually quite short in that range, and then it's 48 in the higher risk. The Gleason scores are 6, 6 and 7, 6, 7, and then 8 to 10. So you can see here that the PSA, the Gleason, and the T-stages are all consistent with low risk, middle risk, 6s and 7s, but 7 is more dominant, which is a higher risk disease. And then in the higher risk, it's a combination of high PSAs and a lot of high Gleason scores. So this is the setup. So you might have quibbles about, what was the adequacy of the pathology? Was it reviewed? Some of them were and confirmed. So, potentially somebody could be a 7, but they're really a 9 if you reviewed the pathology. So there may be a little bit of noise in this system. But anyway, this is what there is, and then this is the treatment that's given. And you expect prostate-only radiotherapy, probably without hormones, in low risk. In the intermediate risk, prostate-only radiotherapy, probably without hormones, and that's the case, 42 to 32. And then the higher risk, you expect almost all of them to receive hormone treatments as well as radiation. So the treatment seemed reasonable. So what are the outcomes? Well, the PSA, this is an example of the interquartile range to start with, and then at 1 year, 2 year, 3 year, 4 year, you usually reach the nadir in Canada as well as here around the 4th year, so the PSA drops quite quickly, as you can see, and then basically continues down. And then there may be some prostate regeneration and shuffling that's happening so that the PSA might come up, but then again plateaus after that. So this is actually characteristic. This is a tumor marker which indicates that these men have exactly the same response to treatment given appropriately, by and large, to men in Canada. So here's the survival, overall survival here, and this is the disease-free survival plot. And what we can do right now is more confidently estimate just the 5-year mark. So just to compare that with 2 studies that would be considered to be perhaps benchmarks for us. One was this study published in Lancet in 2014, and it was a dose escalation study. This is the higher dose group, which matches more closely what we're doing. And you can see that the distribution of the risk groups is actually quite similar to the distribution in risk groups that we have. So this is not a bad comparator because this is a randomized trial. So these are being measured routinely. I've got retrospective data, so these are being measured routinely. Now, this is the estimated disease-free survival at 5 years and the overall survival in that group of individuals on that trial. And this was our estimate, which was 85 and 91. And so they're pretty similar. They're not that different given the numbers of patients included. Now, this was a high risk only. This is MD Anderson. So most people here, if I said you got prostate cancer, I'm sending you to MD Anderson, you might say, well, that's a pretty good place, I'm going to go. Okay, so this is what they get. For their high risk, this is their high risk group, whereas ours has 55% high risk, right? So it's somewhat comparable, but we have some lower risk patients unless they were understaged, right, or under pathologized, so to speak. So the findings of this end-to-end QA are that our outcomes don't appear that different to those published in North American and UK centers for 5-year data. And the PSA profile is basically the same as I've observed in men in Canada. So this would suggest, since these men were generally treated according to the North American guidelines, that in fact males in the Caribbean with prostate cancer, once assigned a risk group, actually can just be treated according to that guideline. There's nothing special about the disease, except that there's no screening going on to detect it earlier. So there's no medical reason for men to leave the Bahamas and go to MD Anderson or somewhere else potentially for treatment. Now, it's true that we need to dose escalate according to the results of these trials, like the one I just mentioned, and it's easier with the better equipment, which currently we have in Antigua, but we'll be going in here within 12 months or so. The situation is that the outcomes are actually pretty good. And one of the things that's important is that the follow-up is limited. That's the main limitation here. because there was a wave of discharging the men in 2010 and then picking up new men after that. So as a result, those up to 2010 were not followed subsequently generally. So sticking with the theme of the conference, it is important to actually have community and the academic centers working together so that the men can actually be followed and care can be given when it's necessary, when adverse events occur. They can be detected and the appropriate action can be taken, including screening for colorectal disease and bladder cancers, depending upon the circumstances. So once you get prostate cancer and get treated, you don't just get the benefit of having the treatment for prostate cancer, you get the benefit of entering a screening program for colorectal disease and bladder cancer. So community needs to work in conjunction in an interdisciplinary way, and this will give us 10-year outcome data. So right now, the average follow-up there for the patients who are alive is about 3 years, allowing a 5-year estimate. But if we actually had the tripling of follow-up data, which should exist out there in those other places, we would actually end up with solid 10-year data, which would be a mature outcome measure. So the extensions for this are that we can fully standardize clinical policies and interdisciplinary teamwork for prostate cancer, because now we have some outcomes to say end-to-end, are we actually doing a reasonable job, and can we dose escalate? We can extract bigger clinical data, we can explore the radiation dose distributions and look to see how that's related to toxicity, so radiobiologic modeling, and hormone adherence patterns, because not all the men routinely go every 90 days and get a hormone injection. Sometimes they'll lapse and not have one here and not have one there, and leave intervals where there's testosterone escape. So they're not covered for the 2 years that they're supposed to be. We can initiate the same studies with this analytical studies in breast and gynecology, and we can start looking at designing prospective prostate studies to properly capture the side effect data and also look at psychosocial and supportive care needs. And we can seek to participate in international randomized trials if we have the opportunity to do so, because we can actually demonstrate that we can actually collect data, and that when you look at the results, it actually looks clinically reasonable. Thank you.
Have any questions? Yes, please.
Higher stage 4 patients are in combination hormonal radiation.
Yeah, they're not metastatic.
So chemotherapy is
Correct, yeah. There is evidence that bringing chemotherapy up early actually leads to an advantage. A number of studies were tried. In a couple of cases, they were actually abandoned because patients were not willing to go on such a study. But actually, upfront triple therapy might actually be superior, but we have to wait for that.
Do we have any further questions? Yes.
You commented that prostate cancer behaves the same way. The idea that prostate cancer is more prevalent in the Caribbean, do you have any comment on that?
I don't think we know, because IARC, the International Association for Researching Cancer, uses only, I think, Cuba to predict the entire Caribbean. And GloboCan, if you look at it again, it is all missing data. And if you go to the Global Burdens of Disease, again, it's all missing data, it's all modeled. So when you actually say, what's the incidence of cancer in Antigua? The answer is it's the world average, because in a Bayesian analysis, the best estimate for Antigua is the world average until you've got data to show that it is not. So if you actually look at the data, I don't believe any of it, because the cases that I'm seeing in Antigua do not match anything as to what they're actually predicted. So it's supposed to be that women are 2/3 of all the cancers in the Caribbean, that breast cancer is most common in the OECS, at least it's supposed to be 35% of the cases, prostate would be 25%. And then we'd have 30% split between GI and gynae, and then there's 10% left over for everything else. So I'm not seeing those cases, and I'm not seeing those cases presented at Tumor Board. So until we actually have registry information, I don't actually think we know whether these things are higher here or not.
But the Jamaica Cancer Registry has been on for years. Published data from Jamaica Cancer Registry.
Yeah, but I don't think these can represent the whole Caribbean. Like, for instance, if I said, well, let's see, the average person in Antigua lives to be about, say, 75, 80, and it's got a reasonably elderly structure as opposed to a young one, so 42% of people in their lifetime would have cancer, like in Canada. If that was the case, it'd be 460 cases out of 85,000 people every year. Well, there's no way there's 460 cases. The flip side is there's supposed to be 80, and I've already seen over 100. So it's not possible for the numbers to actually be correct. So I actually can't tell you what that incidence is.
I remember at a meeting somewhere in Cleveland, and breaking news 5 years ago was do not do PSA after the age of 75. What's your feeling about that, number one? Number two, at what PSA level, let's say in a 60-year-old, would you do a biopsy?
Oh, well, the current cutoff is at level of 3. Now, you have to make sure there's no infection or other reasons. Like with infection and inflammation, you can go up to 130 and you know, not have prostate cancer. So also a large prostate can go up to 15 or 20, 180-gram prostate compared with something like 35 or 40 grams. So you have to take into account these factors. Then you also have to look at comorbidities, life expectancy. The average age here was 65. They might make it to, say, an average of 85. That's the current estimate in Canada. If you plug it into the algorithm in Cancer Care Ontario or wherever it is in Ontario, you get a 50% median survival at the age of 85 for this group of individuals. So with 20 years to go, they have a disease which is likely going to play out. So you have to therefore take an active stance to the disease. So it's true that active surveillance, that is finding they've got cancer and then just following them and intervening only when it gets worse, is a strategy for about 1 in 5 men. The other 4 out of 5 men should move to treat. Yeah.
Just trying to stop it from turning.
Oh, okay.
No, it's okay.
So, yeah, I could just say that in subgroup analyses right now, there are too few events to actually have any significant p-values. So that does not mean that like things aren't trending out properly in terms of higher risk relapsing more frequently than lower risk. But statistically, there's only one p-value below 0.05, and there's over 20 analyses. So right now, that's random noise. There is no statistical significance of any of the predictors, and that includes the use of hormones, the risk grouping, the family history, and so on. Nothing is currently predictive of those plots. Okay, thanks.
Our next presenter, Nina Klein, is the head of research and development at the Tumor Therapy Center in Offenbach, Germany. She studied biophysics at the University of Frankfurt, obtaining her bachelor's and master's degrees. She is part of the scientific team of the Prostate Center at Offenbach, Germany. Her presentation today will discuss prostate cancer treatment with irreversible electroporation, efficacy and safety in 377 patients over 5 years. Let us welcome Nina Klein.
Hi, thank you for having me. I'm going to give the talk on IRE of prostate cancer. My boss, Dr. Stehling, was supposed to give the talk. He's a physician and also a physicist. Unfortunately, he couldn't be here today, so I'm going to give the talk for him. So first, I'm going to just briefly give an introduction, then I'm going to speak about IRE as a treatment alternative to prostate cancer, speak about the mechanisms, how it really works, how the treatment looks like, and also how it compares if we look at radical prostatectomy. Then I will speak about, oops, what's that? There we go. Then I will speak about the clinical applications, so the results that we had, our patient cohort, the diagnostic workup, a couple examples, and also adverse events and recurrence-free survival. So prostate cancer is the second most common type of cancer in men. It is the 5th leading cause of death from cancer in men, and the incidence, just a question that we had from the last talk, it varies, so more than 25-fold worldwide, with almost 70% of the cases occurring in developed regions. This is a map that I pulled up from WHO, and it's color-coded, so you can see it. The darker it is, the higher the incidence. But this is more a matter of screening. So in these developed countries, you obviously do PSA screening more consistently. So this has the effect that the incidence is higher, but the mortality isn't necessarily. Prostate cancer is a slow-growing cancer, so therefore not lethal in many cases, also because it tends to stay in the capsule and not, exceed in most cases, particularly when we look at low-grade cases and if we look at elderly men. And prostate cancer in the black male population, that also related to the question we just had. This graph I pulled up from the CDC, and it shows how many men out of 100,000 got prostate cancer each year during the years 99 until 2013. And as you can see, immediately the red curve is the black male population and has the highest rate of getting prostate cancer. And this shows the death rates, also divided by race and ethics. And as you can see, again, the black male population was by far the most. Sorry. So now I would like to speak about surgery and about the adverse effects you have when you get prostatectomy. If we look at where the prostate is located, it kind of makes sense that we would get impotency rates, incontinence, and rectal damage, because probably everybody in this room knows better, but so I'll just skip through quickly. Obviously, the prostate borders a lot of very important structures, such as the urinary bladder, the pelvic floor, the rectum, the smaller pelvis, and also the seminal-vesicles emerge from the prostate. And the neurovascular bundle is responsible for the erection of the penis and the function of the lower urinary sphincter, and that is obviously located around the prostate and also partially in the prostate. So then it's no surprise that you have these major side effects if you undergo surgery. And this is really how it leads to why IRE, irreversible electroporation, could be a great alternative to treat prostate cancer. It has pretty low toxicity. I will get to that in a moment. But IRE pretty much kills cells selectively, so it's a focal treatment. It preserves tissue infrastructure, and therefore this low toxicity is obviously an advantage for these structures like the neurovascular bundle, the urinary sphincter, the rectum, the bladder, and so forth. So, and this is how it works. So under ultrasound guidance, you insert needles through the perineum into the prostate. In this image, there is a grid. We actually don't use a grid, but you could. And you place the needles in a way that you surround the cancerous tissue or the tissue you want to ablate. And then what you do is you apply very high electric currents in ultra-short pulses, creating an electric field. And this electric field is pretty much the treatment field that you have, and this slide shows really how it works. So the normal cell, as you all know, is a lipid bilayer, and it's semi-permeable, so some molecules go through and some don't. What you can see, I don't know, there we go. So the y-axis The y-axis shows the time. So here you don't have a pulse. Here the pulse starts and here it ends. And here in the images you can see what happens during a pulse. So at first you have the normal cell membrane not disrupted. Then after, let me see, 1 microsecond, pores starts to formate within the cell membrane. And this goes on for as long as the pulse is. In this case, it's 100 microseconds. So by now, you have a pore in the membrane, and you can see it here in an image, actually. That is, there you go. That is irreversible, so it will not go back to normal anymore. The cell is completely covered in little pores. Therefore, the function of the cell, well, the cell doesn't function anymore, and thus it commits suicide. So it goes to apoptosis. So I just have to stress that it's not a thermal method, but it is a focal ablation that is based on, I don't know why this happens. Let me see. Okay, so it's non-thermal and it's based on a cellular mechanism, and it's a focal ablation, and as you have seen from the procedure and how it looks like, it's minimally invasive. And this image, I think, shows really well how it preserves the anatomical structures. So this is a study that was carried out by Professor Rubinsky and Dr. Onik and Mr. Mikis. It was treatment of canine prostate. And this micrograph shows how the neurovascular bundle looks like after electroporation after 2 weeks. And what you can see is both the vessel and the nerve trunk is not affected. There is no necrosis. And this is what the treatment pretty much looks like, the outline of the treatment. So the procedure itself only takes about 2 hours, sometimes 2.5 hours, depends on the prostate size and how long it takes to place the needles. That's actually what takes the longest. The needle placement, you have to make sure it's absolutely accurate. It's done under full anesthesia because you have to have deep muscle relaxation to suppress the IRE-induced muscle contractions that you have. But it's still on an outpatient basis. The only thing that we do is we do a follow-up MRI 24 hours after to make sure just what the site looks like and to see if we have actually treated all of the cancer. And there is, of course, a Foley catheter that remains up to 2 weeks. That's actually the only thing. So the patients are actually very happy with the treatment, but that's the only thing they don't like very much because it irritates them. So. Okay, so the inclusion criteria of the patients we have treated so far are pretty much all patients with all stages, T1 to T4, any type of metastasis status, so any clinical status. They just have refused standard therapies, or they're actually recurrent patients. The main goal for them most of the time is preservation of erectile function and urinary continence. Exclusion criteria is unfit for general anesthesia because, as I mentioned, that's obviously a necessity. And also we have, I think, excluded one patient with a pacemaker. I think it was at the beginning. I personally don't think it's a problem, but I think at the beginning they excluded him. This is our patient cohort. Yes. So again, as you can see, we have all types of patients, low, intermediate, and high, all types of Gleason scores, though most of patients had Gleason 7, most of them even 7A. And then concerning the stages or the clinical status, you can see that the majority were actually organ-confined cancers, but we also had T4. And we even treated, maybe I should point out, even treated BPH as well, which worked because it selectively destroys cells, but not selectively destroys cancer cells. The ideal way for us to do diagnostic workup is obviously because it's a minimally invasive treatment, you will need diagnostic workup. It has to be very detailed in order to do it correctly. So we do endorectal multiparametric MRI as well as bioptic evidence. So this is the evaluation of 377 patients that we have treated. By now, we've actually treated over 400. I think we're at 450 patients now, but this is just the evaluation of 377. And out of those, 263 were treated focally, and this is what it looks like. So as you can see, in this case, it's a patient pretty young. He had T2B, Gleason 7B, and we treated him focally. You can see the result here. So actually this is 3 needle placements. Sorry. 3 needle placements. Here, here, and here. And then you go through all the permutations. So these 2 probes, these 2, and these 2. And then the sum is what you see here. And this is the treatment field. And focally, so we did not treat this side. And 114 patients had whole gland ablations. In this case, it was 5 needles. These are the red circles you can see there. And in this case, the patient had a T2C. It was a PSA 11 nanograms per milliliters and Gleason 8. And after 3 months, his PSA was not detectable. What we can also do is treat very complicated cases and also recurrent patients. In this case, it was a 79-year-old. He came with a biopsy result of Gleason 6. We did not believe that, but he didn't want to do another biopsy before getting treated. He had refused anti-hormonal therapy. So we treated him with IRE, and as you can see, the arrows show that he had a rectal infiltration, and we were actually able to treat the patient with IRE, and afterwards, after 9 months in this case, actually his PSA was high again, but that's because we didn't treat the entire cancer, but mainly the infiltration. So there was still a recurrent or just cancer not treated. And also he was obviously already metastasized. But still, as you can see, I think the orange arrows show that the rectum is completely intact. So it was preserved and he had no problems, but he did still have cancer. And we actually re-treated him. We also did a biopsy while we were at it, and it showed that it was Gleason 8. So the follow-up we did, so as you can see, it's not really a clinical study, it's not a trial. We just asked the patients as much as possible. What we did was we had MRI at best 3, 6, and 12 months after IRE, and then annually, and the same with PSA. And we also completed questionnaires, or asked them to complete questionnaires, urinary incontinence, and IIEF5. And of course, whatever was available from the patient, so PSMA, PET-CT, were given to us as well. This is the recurrence-free survival of IRE so far. This is the maximum of 60 months follow-up. Now, because of time, I didn't put up the other graph, but actually I also had a graph of all the recurrences. Now, but this is actually the true recurrences, because these are the recurrences that occurred after IRE within the treatment field or directly at the margin of the treatment field. So that's, by definition, we would say recurrent. If the patient explicitly didn't want to have treatment sometimes it actually happens, they just want to have the index lesion treated, but they don't want, minor other lesions treated, then obviously that's not a recurrent. But the total of that was 24. Here we have 13. And as you can see, no recurrent of Gleason 6 patients. That's the green line. The orange line shows Gleason 7, and the red line shows everything above that. And what you can see is what I've compared it to is actually the numbers of the Hahn tables. And the Hahn tables are organ confined. So I don't know, maybe I should explain what the Hahn tables are. They consider thousands of patient data of prostate cancer patients that were treated at the Johns Hopkins Hospital. And then they try to predict the probability of prostate cancer recurrence up to 10 years. So I've compared it to that. But again, what they do is oh yes, so the upper limit is organ-confined disease in blue, and the pink one is organ-confined disease. And as you can see, our high-grade recurrence patients are exactly within that line. About our adverse events, it's a mystery why that happens, I don't know. So we did have some mild adverse events. We had transient urinary retention, we had dysuria and mild hematuria, but that went away rather quickly. We had moderate adverse events. It was mainly urinary tract infection, not so much. We had about 2%. And that had to be treated with antibiotic therapy. And then we also had severe or medically significant events, thankfully not so many. It was mainly with 3 cases of permanent urinary retention, and it required to have the tissue removed. Within the prostate that was still remaining. And then we had 1 rectoprostatic fistula that was very at the beginning, I think in 2011. It's still not really sure what happened there, but it was self-healing. And then we had a bladder perforation. My boss likes to say we didn't have these catheter-related problems anymore when we changed the urologist. And we did not have any life-threatening consequence of death. Concerning the evaluation of ED, this is very hard. This is very hard to do, as a lot of us know. We actually also had a talk about that, which I thought was very interesting, but just quickly, because I'm already running out of time, we had severe ED, so we only had about 70 patients actually filling out the forms before and after, and the requirement was that before there was no ED. And T-mean was approximately 180, but really the variation was incredibly high. But what we found was the severe ED only occurred in 6 of these 70 patients. Transient reduction of erectile function was about 40%. But then went down. Transient, by the way, just that's something that I just said, would be after 9 months. So if it went away after 9 months, then it was just transient. And then we also had no change. And concerning urinary continence, we can say that we have literally had no case, not a single case of urinary continence. This is the man who couldn't be there. This is Dr. Stehling, and this is the Prostate Center team. And I thank you for your attention.
Have you tried this with other solid tumors as well?
Actually, we have.
Similar good results?
Yes, so we have treated bone metastasis, also, by the way, after prostate cancer, so metastasis from prostate cancer, also lymph node metastasis. Recently, we have treated breast cancer, so it's all the same, though sometimes with the variation. Sometimes we didn't just do IRE, but sometimes we combined it with electrochemotherapy, which has also been around for a while. So it's a combination of electroporation and a chemotherapeutic agent, which is also highly effective. So it kind of depends on the case, but yes, had good results so far, but not these high numbers.
I'm getting the picture that the alien ship has come and they've abducted us and probed us with these things, and now we're...
It does look scary, yes.
any no way that this could work for the leukemias and so forth?
Yeah, so the thing is, it is a focal therapy, so yeah.
It's ready to allow all the best.
No.
Thank you very much for your presentation. Our next presenter, Dr. Ricardo Davis, is a final year resident in the internal medicine DM program, and he will be presenting his paper, the subject of which is Age Trends of Colon Cancer in Princess Margaret Hospital in the Bahamas, a 10-year perspective. Let us welcome Dr. Davis.
As I said, my name is Ricardo Davis. Happy to present the findings of my paper, The Age Trends in Colorectal Cancer in Princess Margaret Hospital over the period 2005 to 2014. It's performed along with the assistance and supervision of Dr. Curling, as well as Dr. Smith, Frederick Smith. I'm trying not to bore you guys too much. I know it's late and we just want to get out of here. So a little bit about colorectal cancer. Colorectal cancer is one of the third most common cancer in the USA and Europe, and is actually the fourth leading cause of death worldwide, of cancer-related deaths worldwide. It can be treated successfully if detected early, and this is where our screening techniques actually come into play, our techniques as well as our guidelines. However, a lot of the cases are actually diagnosed later in the stage of disease, and so a lot of these patients have poor outcomes. And a study in Canada actually reported that 50%, up to 50% of these cases are actually later staged. And so this comes into play. If you look at the diagram on the right, the top right, the 5-year survival in patients who are diagnosed with localized cancer is actually fairly good, 90%. Even with regional cancers, above 70%. However, if you have distant metastatic disease, it falls off drastically to about 13%. And so it's very important to try and identify these patients early. And so applying educational programs and screening guidelines has actually shown to have a positive impact in decreasing trend over time. And if you look at the bottom diagram, it actually shows that in the US, the incidence of cancer, new cases, as well as the deaths from colorectal cancer has actually been falling over the last 20 years or so. And so this is actually fairly important. And so epidemiological data has become one of the important tools in determining, in the era of evidence-based medicine, determining guidelines and screening practices. And so the epidemiologic data, as we've seen, has been shown for colorectal cancer worldwide, except in this region. And so data trends in the of colorectal cancer in the Bahamas is actually poor. And so what we aimed to do was to determine the age trends, at least, of patients presenting to Princess Margaret Hospital with a diagnosis of colorectal cancer, to give us an idea of our numbers as well as a possible incidence. The methodology was essentially a retrospective chart review of patients presenting to Princess Margaret Hospital who are actually primarily diagnosed with, histologically with colorectal cancer during the period of 2005 to 2014, looking primarily at the age and gender of the patient. Jumping right into the results, we had about 448 cases identified over this period, which gives us an average of about 45 cases a year. If we looked at the trend, you see an overall increasing trend of cases over the time period, with a higher spike in the middle of the period around 2009. And we presume that this was around the time when we actually started to get more gastroenterologists, more colonoscopies being performed, and so you actually got a higher number of cases at that time. The mean age over the study period was actually 62.5 years, which is actually much lower than what we find in the US as well as in the UK, where diagnosis is usually around 72 years in the US and in the UK around 70 years. So this is actually pretty significant. Overall, though, you see that the chart, diagram on the right is showing an overall increasing age, and we are not entirely sure, but we can surmise that there's a possible increasing awareness of colorectal cancer, and so and healthier practices, and so this may be one of the reasons why the age trend is actually trending towards what we find in North America, where we are closely situated. If we look at the distribution of the age of the population, the majority of cases were diagnosed in patients above 50 years old. However, a significant portion, about 19% of the patients, were actually diagnosed below 50 years old, and this is actually a fairly high number compared to our compatriot North American or U.S. data, which actually reports that about 10% of their cases are diagnosed below 50 years old. So it's actually a pretty high number. In terms of the gender analysis, it was fairly even, about 0.95 male to 1 female, which is actually a little bit less than the U.S., and we'll talk about notice that in the discussion. The mean age was actually fairly similar, with the age of 62.4 and 62.1 male to female, so that's not fairly significant in our study. The distribution was fairly even in male and female of age distribution, I should say. However, what we noticed was that over the years, the number of males being diagnosed has actually been increasing, whereas the number of females cases has actually been decreasing. So what does it all mean? Colorectal cancer, as I said before, is being diagnosed a lot earlier compared to the United States as well as the UK. And this is fairly important because we actually use the screening guidelines from the United States as our tool for when we actually start screening practices. As I said, a lot of our cases are actually being diagnosed, a significant portion below 40 years old. And so the thought is whether or not there's an underlying genetic or environmental component that's actually contributing to these findings. Is our screening practice appropriate? Are we appropriately using the North American screening guidelines and methodology to diagnose our patients? And so this is something that we wanted to bring out in this study. The colorectal cancer is also diagnosed fairly evenly in the Bahamas across genders. And this actually sways away from the US and the UK, which actually show a male predominance of 1.3 or to 1.4 to 1. And the age of colorectal cancer is actually a little bit younger in males when compared to females. We didn't find that in our study. And so the question is, what is causing this divergence? Now, one of the things that we surmise is that possibly patients, our male patients, who are a bit averse to presenting to healthcare professionals are actually presenting much later than they should be. And so the age of diagnosis is actually a little bit later. Also, females tend to be a little bit more careful and a little bit more discerning of their body and their health, and they may actually be presenting a little bit earlier. And so this actually brings our numbers fairly even. Whether this is true or not, we can't say for sure. We'll take some further investigation and to looking at the environmental and other epidemiological data. And overall, the rising number of cases in men compared to the falling number in women, what is contributing to this? Is this a lifestyle choice, or we know that our males are fairly unhealthy in the region, or in the Bahamas in particular. We know that their risk factors, or the risk factors for colorectal cancer, include things like obesity, alcohol and smoking, things like sedentary lifestyle. And so we wonder whether or not this is actually contributing to our males actually having a increasing number over this time period, as opposed to the females, who may actually be taking care of themselves a little bit more. Again, this is just a thought. The limitations to this study is actually that it's a population that includes only the public institution. This does not include private data, data from private hospitals or data from Grand Bahama or other islands. And so it's a fairly limited study. However, does this really skew our data? We know that the majority of our patients actually present to the public forum, or to public hospitals or for public care. And so does the numbers, the smaller numbers of patients presenting to private institutions or to foreign institutions actually skew the results of our data? We don't know for sure. The other limitation is that this is not a real full epidemiological study. It did not include our risk factors, didn't include demographic data such as ethnicity, nationality, a stage of diagnosis. And so all of these factors could actually contribute to our findings in the study of age, as well as whether or not the gender ratios are being swayed by any of these risk factors. And so that's something else that we wanted, a limitation, and something else that needs to be investigated. So in conclusion, the study provides some important information, gives us an idea of what the age trends are of colorectal cancer in the Bahamas. To date, this is the longest running study, or longest, most comprehensive study of the age trends of colorectal cancer in the Bahamas. However, there's a lot to be investigated and open doors to further studies. The role of improved education is actually emphasized by the study, I believe. We have to educate our public in terms of presentation and picking up the signs and symptoms of diagnosis, as well as we need to keep our physicians educated so they can actually pick up and appropriately screen these patients whenever they present. We know that there are barriers to the screening process. The colonoscopy is actually we have it available, however, it's resource limited, as well as the patient population may be a bit versed to doing the so-called other studies, stool studies in particular, that may be more affordable, but they actually don't want to go through. So what we hope with this study, that this study will have some impact on national screening modalities and guidelines by the fact that we are showing that an earlier diagnosis is being found in our population, as well as the fact that a younger population is actually a higher, being diagnosed at a higher percentage compared to our compatriot in the United States. And so we want to put forward a thought and the next step as to whether or not we should be using a younger age diagnosis for our patients. We know that our African Americans, which is the majority of our population, do have a more aggressive disease, colorectal cancer. However, the guidelines in the US still do not recommend that you actually to start diagnosing patients early. There's some that do, like the American College of Gastroenterologists, but the U.S. Preventative Task is actually recommending that you still use the same age at 50 years old. And so we actually think that there may be some benefit to starting screening in our patients at a younger age. So I wanted to acknowledge my supervisors, Dr. Curling, Dr. Frederick Smith, as well as my co-investigator, Dr. Sheldon Ferguson, statistics, with Dr. Frankson and Dr. Ms. Nanika Brathwaite at Public Health.
Do we have any questions for Dr. Davis?
Yes, ma'am. This is a retrospective chart review, right?
Yes, sir.
It means you have just collected the preliminary data and you're about to begin the real study now.
Yes, sir.
Because you have left out so many things that for it to have any serious clinical meaning, it has to now go forward in time where you can collect the real thing that you really wanted.
And this is actually in progress, including not just in this institution, but also private institutions. All the data on epidemiology, stage of diagnosis, and all that is actually being in the process of being collected.
Whenever anybody brings a chart review data to the unit, I just go into depression because the chart information might be good for clinical care, but it is so lacking for good research. So
Notice,
let's not let retrospective chart reviews be a favorite way of doing studies for us.
absolutely. Noted, sir.
How can we improve access to screening for we have more gaps on staff, we're not doing screening for
I am not sure if I'm qualified to answer that question. I'm not sure if I'm qualified to answer that question, but we do have, my thoughts were with that, we do have the other more cheaper ways of picking up patients that may be at risk for colorectal cancer, like the fecal immunochemistry testing or the fecal DNA testing. Those things can actually, they're not but maybe we can invest in that. And then that could be the gateway to actually screening our patients and sending them for the colonoscopy as needed. And absolutely. Absolutely. Yeah.
My other issue was, in terms of, there are several programs for cancer. Survival cancer is one, colon cancer is another. The ongoing issue is we save so much money on the front end if we can do screening.
Absolutely.
The fact that insurance companies often do not cover screening colonoscopies.
Okay.
I know nobody can explain that to me in rational terms. Why would you not invest in colonoscopy that's going to save you money on the front end rather than spending hundreds of thousands of dollars for treatment?
I don't know if I'm gonna
$3,000 every 2 weeks. This website doesn't make much sense to me, but it's getting more expensive. So, does anybody that can agitate for them and advocate for them and for them covering that cost, that would be wonderful.
Absolutely.
Okay, final comment from Dr. Dabo.
There are some problems about maybe the age of science scale, especially in people who have colon cancer in the family.
Risk factors. High risk.
You have colon cancer in the family, you should have your first colonoscopy 10 years before the age at which your family member
Right.
was diagnosed.
Right.
And then in Vermont, colon cancer gets bad rep, and we, the physicians, don't do enough education of the patients about screening. Breast cancer is a big deal, and everybody on the road collecting money and all this. And you don't hear anything about colon cancer, colon cancer. So I think we as physicians, we
One quick comment on that. Just one quick comment on that. Yeah, it's a problem. Okay. Thank you very much.
Thank you. We're going to move on to our next presentation. Our next speaker, Spencer Delaveau, is a final year medical student with the UE School of Clinical Medicine and Research. His Subject of presentation will be breast cancer trends in the Bahamas, a 16-year review.
Sample size was about 1,500 patients. As you can see here, the largest group was the 40-49 age group, followed by the 50-59 age group, and 60-69 age group, and finally the 30-39 age group. This pie chart is just another graphical representation of the same information. As you can see, the 40-49 age group and the 50-59 age group consists of almost 50% of all patients diagnosed. And when you incorporate the next two largest age groups, the 30-39 and 60-69 age group make up almost more than 75% of total first-time diagnoses. When you look at the average age of diagnosis, I found that the average age of diagnosis was 54.5 years of age. And over the study period, I saw that there's a gradual, although not consistent, increase in diagnosed age. The lowest average age of diagnosis was in the year 2000 at a little over 50 years of age, and the highest age of diagnosis was in 2014, which was the end of the study period, at a little over 57 years of age. Also interesting was that over the first half of the study period, the average age of diagnosis was about 53 years of age, and over the second half of the study period, the average age was 55 years of age. And not only do we see an increase in average cases and average age diagnosed, but also in the average number of cases diagnosed, where in the first half of the study period, we saw that the average number of cases diagnosed per year was 73. And in the second half of the study period, we saw an average number of cases of 103. So that's an increase in almost 30 cases per year. If we go into the different age groups, we see that only the 30-39 age group saw a relative decline in the number of cases of breast cancer through the study period. And 40-49, 50-59, and 60-69 age groups saw a minimal increase during the study period. So what I then did was I used data from the SER database in the United States, and I compared it to the data that I collected here at home. And I used the data from 1998 to 2012 for this purpose. When you look at the number of patients below age of 40 in the United States, you see that they have about 4.73% below this age cutoff. Whereas in Bahamas, I saw there's a 15% of our patients were below the age of 40, and this trend continues. So when you look at patients below the age of 50, USA has about 22%, whereas the Bahamas has almost double this at 41%. And in continuing with the trend, in the number of patients below age 60, you see 47% patients in the United States diagnosed below age 60, but in the Bahamas, we have more than that at 64%. And this is important because depending on which guidelines you use, you can start screening at age 40. So where the US can capture at most maybe 95% of their cases by starting screening at age 40, the Bahamas is capturing almost 10% less at about 84%. As for the data I collected, I continued to a comparison, and I think perhaps this is the most important slide. I compared Bahamian data to that of the United States overall and to the African American ethnicity specifically. And I did this because it's been shown that African Americans have experienced breast cancer at a younger age and had higher rates than Americans overall. And people think that, okay, Bahamians are mostly of African descent, so our rates should reflect this. And what I show here is that the patterns are different. So like I showed before, the 40-49 age group in the Bahamas is the highest per group of incidence and first diagnosis of breast cancer. But when you look at the United States overall as a group, 50-59 is the highest age group. And when you look at African American ethnicity specifically, they continue that trend, although higher than America overall. In keeping with the trend, they have the highest age group at 50-59. So what I show here is that although we are of African descent for the most part, our patterns of breast cancer incidence are slightly different than what we would expect. So what we conclude from the study is that first, the mean age of diagnosis in the public sector is 54.5 years of age compared to that in the United States of about 61. And when you look at the average age from 98 to 2014, we've seen an overall and gradual increase in that age of diagnosis. Also, in addition to that, we've seen an increase in the number of cancers, breast cancer cases diagnosed from the first half of the study period to the second half of the study period. And the 40-49 age group makes up the largest age group of first diagnoses at 26%. We also see that from 98 to 2012, the percentage of patients diagnosed with breast cancer under the age of 40 is 15%. So where do we go from here? Like Dr. Davis showed, despite population differences, are our current national screening guidelines adequate? And in addition to this, do we have enough information to decide this? And I think the answer is no. I think we need more information, more data collected. And as we know, collecting data in the public sector is a bit difficult. So I think additional parameters such as mortality, stage on diagnosis, as well as breast cancer type, the specific type, would all be helpful in continuing this analysis. And in addition to this, when you look at screening technologies available to younger age groups, for example, the 30 to 39 age group, we know that screening for breast cancer in these age groups is a little more difficult because of the characteristics of the breast tissue. So how would we go about doing this if this was the case? And something that just caught my eye, I thought was a little interesting. Just last month in New England Journal of Medicine, there's an article published on using genomics as a method of screening. And what they did was they used a 70-gene signature, as the title says, as an aid to treat early stage breast cancer. And what they showed is they used the 70-gene signature to calculate a patient's genetic risk, and they categorized it as either high or low genetic risk. And despite having high clinical risk, those patients that had low genetic risk and were treated only experienced a 1.5% higher 5-year survival than those who weren't treated. And they estimated that 46% of women with breast cancer who had a high clinical risk might not require therapy. And in these current economic times, especially in the public sector, this would be a huge benefit for our patients if they didn't have to invest time, effort, and emotion into chemotherapy. So I think, although this is sort of relatively new technology and something that hasn't really been developed yet, I think this is something to keep in mind in the coming days. And in addition, as I showed, our pattern is different. So we would also have to investigate what our gene signature in our community, in our population is, because what they use as their 70-gene signature might not be adequate for our local population. So I'd just like to close and say, one, more data is needed to gain a better understanding of our local trends and the impact and adequacy of local screening guidelines. And two, these data points are needed for careful interpretation of the dynamics within our population to ethically implement healthcare in Bahamas. I'd like to acknowledge Dr. Curling and Dr. Francis for their supervision, and those were my main two sources. Thank you. Any questions?
Are there any questions at this time? Dr. Carter?
When are we going to finally see the incidence going down? How can access to breast cancer screening, but we're not seeing an impact on incidence rate? So why is that?
That's a good question. Thank you. In terms of how we screen for breast cancer, I think there's been a lack of emphasis placed on the genetic risk. We've had a few studies, about 3, I think, showing that there's a very strong genetic impact in terms of, we have, I think, 6 founder mutations that are very specific to our population. And so until we can address the genetic aspect of that, I think we may have to wait a while to see a reduction. Good.
Congratulations, first of all, on publication. Back to Dr. Roberts' question, do we really screen? What are our screening protocols that we have in place to capture these women who are just they present with enough for some suspicion? How do we capture?
So, in the younger age groups, I think it's based on suspicion. I think in the public sector, we tend to see a lot of late-stage diagnosis when the clinical aspect is already fully developed. And but as far as our guidelines here at home, I think we tend to follow the U.S. Preventive Task Force. And so I believe they have the option that's starting at 40. Yes, Dr. Roberts?
Just want to let you know, one time the ministry decided they wanted to screen, and they got this big van. And it was supposed to go to the community. Instead, right underneath the building, the ministry never went a damn spot. So the average person who are healthy, at risk, that should be screened, it never happened. He don't screen.
Okay.
Not in the public sector. But I mean, the private is the same thing you know in the private sector. That's what you guys was done. If you do want license,
Take some time.
Okay, one other final comment, Dr. Roberts.
I think going forward is the fact that we always knew anecdotally that we had a something else going on that's not just BRCA+. Okay? There's a lot of issues going on here. But this is the first stepping stone in helping us come up with guidelines. If it's going to be 40, if it's going to be 35, or whatever exactly it is, but we have to start somewhere.
Thank you.
Dr. Dames, you have a comment?
Genetic pool that we have, but my question is that we know that triple negative disease or breast cancer tends to be more aggressive and we don't have to treat. It doesn't respond to treatment very well. Do we have an idea of how many of our patients, percentage-wise, may be triple negative, and it might explain the aggressiveness and the presentation that we're seeing?
Well, I can tell you this, can't say specifically, but it has been postulated that the women younger than 40 years old, we suspect the majority of them are triple negative disease. That's part of the reason why they present so early. Suspect. That they present so early and they don't respond to a hormonal therapy.
That's my next PowerPoint. That's my next PowerPoint. Have they let that get to?
And this presents another issue in that you find a population of patients that can afford to go to the states that mostly have oxygen effect. The way that they treat breast cancer here is very different, and they don't treat it in the US. They don't see the type of cancer that we see here. So us being aggressive and their lack of aggressivity in the way that they approach it is two different things. Triple negative disease, if you see a woman younger than 41 and likely, you can postulate that the majority of them are triple negative or repeat. That means we don't have the options that we would have if they were the positive and we give them hormonal therapy. They have no options, traditional chemotherapy, and in some cases, hopefully, can't even use targeted therapy in them. So their disease is more aggressive, and they often die younger because of that. And these patients also present at a later stage.
Okay.
Thank you.
Thank you, Spencer Delaveau.
So then the only option we have is obesity management.
Okay, Dr. Frankson. No.